בבקשה.
ערב טוב, כאן נגב בר, רופא משפחה ויושב ראש החברה לרפואת שריר והשלד. אנחנו מאוד שמחים לארח אתכם בוובינר החמישי עם דוקטור סיימון וולפסון. מספר מילים באנגלית ומיד חוזר לדבר בעברית. Hello and good evening, this is Dr. Negev Bar, the chairman of the Israeli Society for Musculoskeletal Medicine. We will start the webinar with Dr. Simon Vulfsons in a few minutes, and I'll say some more introduction words in Hebrew. מיד אני רוצה להראות לכם את התוכניות שלנו לשבועות הקרובים, מיד להעסיק אתכם למספר שניות לפני המצגת של דוקטור סיימון וולפסון. אז מיד באמצע הקיץ ביולי, ברביעי, חמישי, 18 ו-19, יש לנו את הקורס דיקור יבש מתקדם, פלג גוף תחתון, הרשמה באתר החברה, תתקשרו ליעל אור או מזכירת החברה, תוכלו לראות את הטלפון שלה באתר החברה, מצוין פה למעלה מעל האתר, בראש השקף. אתם מוזמנים להירשם, יש עדיין מקומות. יש לנו גם עדיין מקומות, מספר מקומות מצומצם לקורסי הדיקור יבש הבסיסי, שיש לנו בחודשים הקרובים. הקורס במכון הפיזיותרפיה באסף הרופא, הרשמה נסגרה, אבל יש לנו כן מקום, מספר מקומות בודדים בבית החולים רמב"ם בחיפה, וגם במרכז הדרכה של קופת חולים מכבי בתל אביב. אתם מוזמנים להתקשר ולברר פרטים נוספים או להסתכל באתר. זהו, ואני מאוד שמח לארח את דוקטור סיימון וולפסון, מנהל מכון לרפואת כאב בקריה הרפואית רמב"ם, חבר הוועד החברה הישראלית לרפואת שריר ושלד ונשיא פי"ם עד לאחרונה, עד לפני כחצי שנה, וכיום חבר ועד הפדרציה הבינלאומית לרפואת שריר ושלד. דוקטור סיימון וולפסון, בבקשה.
Our friends here from Israel and all our colleagues, but also probably friends from overseas who want to possibly share in the webinar either now or later. And for this reason, I've prepared the slides and so on all in English. And I will be speaking in English. If there's any problem at any stage, please don't hesitate to stop, ask Negev, and he'll transfer any questions on to me. So we're going to start from the beginning. And the question is here, myofascial pain, is it primary or secondary, and does it matter? So let's go on immediately and see what we're talking about. Okay, there's an example of a woman. She's 23 years old, and she's been suffering from migraine or migraine since she's been her teens. She's seen numerous neurologists and has received medical treatment. And the diagnosis is classical migraine or classic migraine. Interestingly, that on examination, multiple trigger points have been noted on her scalp and especially in the neck area. And the question is, what does that mean? So she's got headache pain. This would probably be the area where we would imagine that she would feel her pain. And she has multiple trigger points. What is the meaning of those trigger points? So I want to ask you a question right from the beginning. And Zohar, this is a time for you to get in. This is an online poll. Exactly, you can see poll open. Poll must be closed and able to enable screen sharing. Which of the following headache types are associated with a high probability for trigger points? It can be one or more. So just put your answers in, and Zohar, when you're ready, you can show us the results of the poll. We'll give maybe 30 seconds or up to a minute for that.
אז כדי להצביע צריכים לסמן את התשובה וללחוץ submit.
Okay, so you have to click and open up and decide which of the following have a high probability for trigger points. Right. And Zohar, can you tell me when the poll is ended, please?
Yes, more than 56% of the attendees. So I closed now the poll. Let's
Okay,
share the results.
can we see the results?
Yes, אז 81 בחרו תשובה ד' ו-19% בחרו תשובה א'.
Okay, okay, that's very good. So let's have a look. According to the International Headache Society classification for headache disorders, if we look at the common disorders that cause headache and the probability for myofascial trigger points, we can see that, in fact, yes, migraine headache, high probability, tension type headache, very high, and of course you were right. Cluster headaches, not so much. But we can see headaches associated with dental and TMJ problems, which wasn't in part of the poll, also high, and headache associated with trauma can be moderate to high. So headache and myofascial pain, how common is this in fact, and do we regularly see it? In 2006, there was an article published by Fernandez de la Penez. I won't go into that one too much, but he has found and described multiple myofascial trigger points in unilateral migraine. And there was another study that was published by Delgado in 2009 in medical oral pathology and oral something or other buccal. I can't remember exactly, but it's this is a journal that deals mainly with oral pathology, and they found high prevalence of myofascial trigger points and masticatory muscle dysfunction. Another one, also, this is an older article from 1992 by Bovim. There was decreased pain pressure threshold in cervicogenic headaches. In other words, patients suffered from more pain, or the pain threshold was much lower, patients suffering from cervicogenic headaches. When we look at the question of headache and myofascial trigger points, so this is a study still done with David Simons when he was still alive, and Cesar Fernandez de la Penez. And what they found was that peripheral and central sensitization may be involved in the development of chronic headaches. Central sensitization is driven by prolonged nociceptive inputs from the periphery, such as active muscle trigger points. And based on the available data, it seems that the pain profile of neck and head syndromes may be provoked by referred pain from trigger points in the posterior cervical, head, and shoulder muscles. And this is really fitting, and we know this is compatible with what we know. You can have a look over here and see this picture here. You can see the upper trapezius muscle will often send, trigger points will often send pain in the area, which is similar, very similar to migraine. Sternocleidomastoid, the same, suboccipital muscles, and the splenocervicis muscles. So basically what we're talking about here is a real overlap syndrome between headache and myofascial pain syndrome. Moving down, let's take another example. 47-year-old woman, pain in her right shoulder for 4 months. After a workup by an orthopedic surgeon and a rheumatologist, it was decided, or she was diagnosed with adhesive capsulitis, frozen shoulder, as you wish. But on examination, she has not only marked limitation of range of motion, especially external rotation, and I'm sure a lot of you will immediately recognize that if she has limited range of motion on internal rotation, possibly the subscapularis muscle is involved, and she has multiple trigger points around the shoulder girdle. So again, we ask ourselves, she has adhesive capsulitis, which seems to be a primary problem of the glenohumeral joint. Why should she have trigger points? So when we're talking about shoulder pathology, I want to ask you a few questions. If a patient has myofascial pain, in other words, trigger points in the shoulder area, for whatever reason, which muscles do you believe are the most commonly involved? And again, Zohar, if you're prepared to open a poll, if you could you indicate which muscle you think is the most commonly involved, one of the 4, or maybe more.
So again, click the right answer, the single right answer, and then click submit.
That's right. Okay, and when we get to about 50–60% of the people who've answered, we can close the poll and you can give us the results.
Fine. Almost half of the people. Okay, let's share the results.
Okay.
So 50% על התשובה א', 33 תשובה ב' ו11% תשובה ד'.
Okay, so most of you answered supraspinatus. Well, interestingly enough, a study was done with Bron and Domerholt. Domerholt, some of you might recognize the name. He's the physiotherapist who works with, or has been working with, Robert Gerwin for many, many years. They saw a high prevalence of shoulder girdle muscles with myofascial trigger points in patients with shoulder pain, exactly the question we were asking. And what they did was they measured for 72 patients. Inclusion criteria in this study were unilateral non-traumatic shoulder pain. Outcome measures were passive range of motion, myofascial trigger points, VAS score, and DASH DLV score, which is a score of shoulder disability, Dutch version. This study was done in Holland. And all patients had myofascial trigger points in the shoulder girdle. The average was 6. Range from 2 to 12. That's a mistake. I apologize. 2 to 12. That's a range. And when we look at which muscles are involved, first of all, we can see here the number of active and latent myofascial trigger points per subject, and you can see that mainly 6. 6 was the average amount. And when we look at the muscles, interestingly enough, you all mentioned supraspinatus. But the main one is infraspinatus. Infraspinatus is the most common muscle that you will find with trigger points. Up to 60% of patients with shoulder pain will have trigger points in infraspinatus. And then the upper trapezius, of course. You can see here middle deltoid. Supraspinatus, which I believe is very, very common, only showed about 20 to 30% of the patients. And the supraspinatus muscle here, for some reason, yes, here it is. It's 20 to 30 as well. Sorry, the supraspinatus, the subscapularis is 30%. That's the one that I feel is very commonly involved. But this was their study, so it's interesting to notice that patients with shoulder pain, look at the infraspinatus first of all in the upper trapezius to see where they've got trigger points. Okay, so let's move on a little bit. This is a review by Sergienko and Kalichman. Leonid Kalichman, as you all know, is the head of physiotherapy in Beersheba. And they did a review of the myofascial origin of shoulder pain literature review. This was published in 2015. And their objective was to examine the current evidence associated with myofascial origin of shoulder pain, with emphasis on diagnosis, prevalence, and treatment efficacy. Well, 3 different studies concerning the prevalence, this is what we're talking about, showed increased prevalence of myofascial trigger points in patients with unilateral myofascial shoulder pain, unilateral non-traumatic shoulder pain, and also impingement syndrome. So this is a second line or a second area where we can see that patients suffering from shoulder pain have increased prevalence of myofascial trigger points. And there are other studies. Here's a study by Page concerning adhesive capsulitis, which we discussed before in 2010. And Kalichman and Ratmansky, Moti Ratmansky from Beit Levenstein, Kalichman from Beersheba, they also published a paper in 2011 on patients with hemiplegic shoulder. So we're talking about patients who've had a stroke, mainly. And they have a stroke and they have neglect and they're not moving their muscles so much and they're not using their shoulder and their upper limb. And they develop myofascial trigger points. And this is also found in their study. Let's move on to the back. Okay, so what have we got in the back? We've got a 53-year-old man, and his pain is in his lower back. He's had it for a month. He's been worked up by an orthopedic surgeon, and the diagnosis in the end was non-specific low back pain. Doesn't seem to have a radiculus syndrome. On examination, he's limited in his range of motion, and he has multiple trigger points in the rectus spinae muscles. So Gerwin in 2014 in an article for Physical Medicine Rehabilitation Clinics of North America discussed the most important causes, non-myofascial causes for pain in the lower back. And we're talking about facet arthropathy, ligament pain, soft tissue damage, and possibly you could put myofascial trigger point or myofascial pain there, spondylosis in general. And when we go to Travell and Simons, not only the recent edition, the 3rd edition, but also the 2nd edition, which probably all of you know, and we look for the myofascial causes of low back pain, we see that basically we can discuss the lumbar area, and we've been talking mainly about the iliopsoas muscle, the rectus spinae, and the multifidae, and also the sacral and gluteal pain area. And here we're talking about back muscles again, with the quadratus lumborum, and of course the muscles over the buttocks, the piriformis, glutei, the vaterani, and all these are very, very common syndromes for myofascial pain. But then let's look at this patient, and if you've heard lectures from Negev, you would have heard something similar about this kind of patient in the past. And we're talking about a 62-year-old man, and he's had back and right leg pain for a couple of weeks. His SLR is slightly compromised on the same side, and he's got mild weakness. His ankle jerk is diminished bilaterally. And the diagnosis made by the orthopedic, by the family doctor, by a neurologist, by the pain clinician is lumbar radicular pain. Okay. On examination, he's got limitation of motion, tenderness. We talked about his SLR, which is slightly compromised. And interestingly enough, multiple trigger points in the gluteal muscles. And the question is, what has he got? Has he got a radicular syndrome? Has he got a myofascial syndrome? Has he got both? So when we look at the composite picture of gluteus medius and minimus pain maps, we can see this kind of picture, which is very, very common. Pain could be either just in the buttocks area, maybe the area of the sacroiliac joint. Maybe it could be over the area of the lesser trochanter or the greater trochanter and looks something like trochanteric bursitis. Could be something which looks like a typical lumbago. And then we've got these two pictures here with the gluteus minimus trigger point, and we're talking about something that looks like a radicular syndrome. Anyway, this question is gone back and forth, and I want to present this study, which I'm sure some of you have read and heard about. Again, if you've heard any of Legev's lectures, you would have heard about this because the main researcher here worked with Negev in Montreal. And the question is there an association between lumbosacral radiculopathy and painful gluteal trigger points? So a patient could have a radicular syndrome, and he could also have painful gluteal trigger points, and is there an association between the two? So what did they do in this study? And I'm going to spend a little bit of time here because I think it's fascinating. First of all, they took patients with low back pain that were referred to the pain clinic. And before they examined for radiculopathy, they examined to see if the patients have got gluteal trigger points. That's quite easy to do. Lie the patient down on their stomach and use a pain algometer, which is a small little device that you can press on and see the amount of pressure that you're using. And the patient will tell you if he has something which seems characteristic of a trigger point. That's what they did. And they documented that. After that, they took the history. For control patients, that was it. Okay, the control patients were examined for trigger points and then sent home because they're not suffering from pain. The patients, though, had a physical examination, and the physical examination, if it seemed to be congruent, had a lumbar MRI scan. If that was fine, electrophysiological studies, including EMGs, and excluded from here were people with normal EMGs, and eventually they got to the diagnosis of lumbosacral radiculopathy. So this is quite a rigorous study in the fact that the patients who were measured against the trigger points were those who, with a high degree of certainty, had lumbosacral radiculopathy. Okay, so this was done by Farhad Adelmanesh, and was printed. It was published in the American Journal of Physical Medicine Rehabilitation in 2015. So what are the results of this study? Well, okay. Look at this table here. You can see the concordance between the side of the gluteal trigger point and the patient's complaint. So this is the side of the complaint. Healthy patients here did not have any trigger points, okay? There was one trigger point on the left side. 2 patients had bilateral trigger points out of 152 patients. So that's 2 out of 150 or 3 out of 150. That's more or less 1% of patients had a trigger point. Normal, healthy patients. Patients who had what seemed to be a right-sided lumbar radiculopathy, 86 or 76% of the patients had a trigger point in the gluteal muscles on the right-hand side. Similar on the left, slightly lower. Okay, 70 patients who had left-sided pain, but again, it's 73% of the patients had on the left-hand side. And those who had bilateral complaints, 38 or 38.7% of patients had trigger points. So the the results are that if you have a lumbar radiculopathy, there's a good chance that you're going to have trigger points in the gluteal muscles on the same side, quite high prevalence. And if you don't have a lumbar radiculopathy, there's a good chance that there won't be any trigger points whatsoever. Interesting. But let's ask the opposite question. So if a patient has trigger points, let's say, to what extent will that finding predict the presence of radicular syndrome? Now, this is common. All the time we see patients coming to us with low back pain, occasionally with leg pain. Yeah, Zohar's already opened the poll. And I just want to explain a little bit more this question. So patients come with back pain, leg pain, and we examine them and we find trigger points. To what extent does that predict that the patient actually has a radicular syndrome? So is it to a great extent, to a mild extent, or is there no connection whatsoever, to a low extent or no connection whatsoever? So just one of these you have to answer. Please just click on one of them and then submit your answer. And Zohar, when we get to 50–60% of the participants, you can tell us that the polls are finished. How are we doing, Zohar?
40%.
40%. Okay, think a little bit more. Again, if a patient has gluteal trigger points, to what extent will that finding predict the presence of radicular syndrome?
Okay, like last few seconds.
The second one, mild extent?
Okay, now I'm closing the poll.
Thank
Let's
you.
share the answers. Okay, תשובה א' 20%, תשובה ב' 50%, ג' 25% וד' 5% בלבד.
Okay, so most of you thought to a mild extent. Well, let's have a look. So Adil Manish, he did a further study or further examination, and he exactly asked that question: what is the diagnostic accuracy of gluteal trigger points to differentiate radicular from non-radicular low back pain? Okay, so you can all look for it and read it. If any of you want the article, I have it obviously, and I can send it to you via email. But here we can see that if a patient has gluteal trigger points positive, then the chance that he has radicular low back pain, according to the same standards they used before, was 137 out of 149, high. And if a patient doesn't have trigger points, okay, the chances are he has non-radicular low back pain. This is fascinating. So gluteal trigger points test could accurately predict radicular pain in the majority of patients referred with low back pain. What does this mean to us? That's the interesting question. It was high specificity and sensitivity, or relatively high. So this is really a question now that we have to ask ourselves. Next patient who walks into the clinic has got trigger points. There's a reasonable high predictive value for these trigger points in the fact the patient might have a lumbar radicular pain syndrome. This is fascinating, and this is exactly what we're talking about. And what do we do with it? Does that mean that that patient needs to be sent off to a pain clinic for an epidural? Does that mean that patient needs to be operated on, etc.? Well, these are interesting questions. Maybe I'll get to that a little bit later. Let's go somewhere else. Breast cancer and breast cancer surgery. This is something that is very common, unfortunately, in this day and age, and 1 of 9, 1 of 8 women suffer from breast cancer. Many women, or almost all women, obviously undergo lumpectomies, and some of them undergo mastectomies. And we know that there's a very high incidence of mastectomy, post-mastectomy pain syndrome. The question is, what is that pain? And up to now, most authors have considered post-mastectomy pain syndrome to be a neuropathic syndrome. Well, this is interesting. Again, this is a study. You can see here that Bob Gerwin was associated with the study. And this is 116 women, 1-year follow-up, post-mastectomy. 52 women, in other words, 44.8%, developed a myofascial pain syndrome after the mastectomy. Not a neuropathic, a myofascial pain syndrome. And I think that's a very important result. So why? What's happening here, and why are so many myofascial pain syndromes appearing in these women, and not just neuropathic? And then I was looking through the literature to see whether there were other interesting syndromes that are associated with increased risk of myofascial pain. And I found this one on insomnia. This is a huge study. Almost 8,000 patients participated. And the incidence risk ratio of myofascial pain syndrome between insomnia and control patients was 2. In other words, you've got double the chance of suffering from myofascial pain syndrome just because of the fact that you're suffering from insomnia. Also, very interesting result. And then we go further and we look at something like visceral pain. Okay, those of you who participated in the conference in February, and not only our myofascial pain conference, but also the neuroscience conference that took place, and were able to hear the lectures of Maria Giamberardino from Italy, heard fascinating material about visceral pain and myofascial trigger points. And here we have not only visceral pain, but endometriosis, specifically chronic pelvic pain. And there are plenty of studies that have shown, and again, I'm not going to go into that too much detail, but 2001, 2009, 2004, lots of articles written about the fact that there's an increased risk of myofascial trigger points and myofascial pain syndrome in patients suffering from chronic pelvic pain, endometriosis, also in men, by the way, not only in women. Let's go on to something even more bizarre, more interesting. CRPS and myofascial pain syndrome commonly occur coincidentally.
Simon?
Yeah.
Simon, just a minute. There's a question from the audience. If may I interfere here?
Sure.
There's a question from, I don't see the name, but has anyone investigated the chronological order of appearance regarding trigger point and the radicular? What comes first? What appears first? The radicular pain or the myofascial pain?
I'm not sure. I don't know concerning the radicular and the myofascial. That's fascinating. In the study that was done by Adnan Manesh, he took patients who were suffering from pain, and then he went ahead and examined to see where they had trigger point and where they had a radicular syndrome. So that in itself is a very important question, and I don't know. I can mention that many times, and I remember in particular one case at our clinic in Rambam many years ago. I remember Amir Minerbi treating a patient who clearly had a myofascial, clearly had a lumbar radicular pain syndrome and was waiting for surgery. And everything was positive, including the MRI, which showed a huge disc protrusion. The examination really wasn't very strong as far as the weakness of the leg and loss of ankle jerk and so on. And there were trigger points especially in the gluteus minimus muscle, and he treated that, and the patient got better. So this was really one of the first times when we started looking and saying, wait a second, these things go together. But what occurs first, I don't know. If we look at the hemiplegic model, hemiplegic shoulder model, obviously these patients were normal. They were healthy beforehand, probably didn't have trigger points or nothing more than latent trigger points in both shoulders, and then they went ahead and they developed a hemiplegic syndrome. Excuse me. And this syndrome was obviously the precipitator, and after that developed myofascial trigger points. So I'm not sure. That's a good question, but I would say that in some patients it would probably be very common that the inciting factor was in fact another disorder. Look at the endometriosis, for example, as a visceral disorder, which afterwards causes development of myofascial trigger point. Giamberardino discussed that actually in February quite extensively when she talked about the fact that you can have patients with visceral pain and referred pain to somatic structures causing myofascial pain. The visceral pain can disappear, and the patient can be left with a myofascial syndrome. Okay, so I hope that answers the question. Any other questions, Negev?
No, you can continue with the CLPS. Thank you.
Okay, so let's look at the CLPS model. This is really interesting as well, because this picture, by the way, is taken from a clinic in Kupat Cholim here in Haifa, I think 6-7 years ago. This is a woman who had CLPS of the right hand, and you can see very clearly here not only the swelling, but the incredible sympathetic output and the sweating, color discoloration, and so on. And this is her hand. I think it's a week later, after she was needled, dry needled, for myofascial pain syndrome of the proximal muscles. The idea was, and again, this was a mere just by chance, this particular case. Yeah, Amir said to this lady, listen, I can't help you with your hand, but you've got a huge amount of trigger points further up in your shoulders and so on. Let me needle those and maybe that will relieve some of the pain. And this is what happened. We went ahead and then started looking actively for patients with CLPS and CLPS-like syndromes. And most of these patients, because they don't move their hands and they don't move their upper limb, same with the lower limb, they will then go on to develop trigger points and dysfunction of their whole upper limb. And so we can go ahead and treat the upper areas. And this is quite amazing. A doctor by the name of Vass, interesting name, but his name is Vass, an Indian doctor, has written quite extensively about improvement in CLPS after deep dry needling of proximal muscles, and he suggests a role in myofascial pain in the development of CLPS. So the question is, myofascial trigger point, are we talking about a peripheral phenomena? We're talking about a central phenomena, and again, this is a very nice editorial. But it appears that trigger points are a common primary dysfunction. We see it very often, especially in the primary care clinics, and not necessarily secondary to other diagnoses. So let's imagine that you're sitting in a primary care facility in a clinic somewhere, and the patient is bent over, try to pick something up, and he suddenly gets a twitch in his back, and he comes running into the clinic with, or not running, he comes in limping with severe pain in his lower back. And that could be a primary diagnosis. We could talk about possibly about rectus spinae, quadratus lumborum, psoas, etc. But it can also be a comorbid syndrome associated with a variety of medical and musculoskeletal conditions, and I've discussed this extensively. Let's take the subscapularis, for example, one of my favorite muscles, both as a syndrome. So the patient could have local pain because of myofascial trigger points. And he can also have pain which seems to be referred, and possibly this is the central sensitization of the initial incident. So let's say the subscapularis muscle has suddenly developed shortening, tightness, tight bands, etc. We would have the local pain and also the referred pain. And this is what Dumaholz and De La Penez are discussing. 2014, interesting article. So patient comes in, we evaluate them. If the pain syndrome does not have any myofascial involvement, then we go ahead and we treat the patient with whatever we decide, and the outcome will be what it is. And I'll discuss this in a second. Very possibly the patient comes and it appears that there's myofascial involvement. In other words, we will see tenderness, trigger points, shortening, weakness, all the things that we know are associated with myofascial pain. Now, if it's primary myofascial pain syndrome, such as we see often in primary care, then we can treat that, needle it, treat it, and so on. But often there's a primary pain diagnosis with secondary myofascial pain. So what do we do there? Do we treat the myofascial pain in that situation? Do we treat only the primary pain diagnosis? This is the conundrum. I'll go into that again a little bit, another few slides down, but obviously the primary myofascial pain syndrome should be treated. We'll see what the outcome is, how the patient is, if it's an acute torticollis because of sternocleidomastoid muscle suddenly go into spasm, or quadratus lumborum or whatever. We'll treat that. Hopefully the patient will get better, go home, and write us a thank you letter saying that we're magicians and wonderful doctors. If it's secondary myofascial pain with primary pain diagnosis, with a primary pain diagnosis, we obviously have to broaden our outlook and decide what we're going to do, how we're going to treat, and what the outcome measures are. So let's take a look, and obviously we reevaluate as necessary. So let's take a look at the pain syndromes which don't seem to have a myofascial involvement, at least initially. Example would be acute herpes zoster neuritis. Maybe, and this is a mute question, but maybe the acute stage of fracture of distal radius. We've got a pain syndrome, possibly without myofascial involvement in the first day or few days. Chronic ischemic heart disease, delay onset muscle soreness, but all of these, obviously, some of you might say, wait a second, chronic ischemic heart disease is a visceral pain syndrome, and there might also be associated myofascial pain associated with it down the arm, obviously. Vertebral fractures with metastases. These we would consider things that we should treat primarily the major disease here, osteomyelitis as well. Often we see pain syndromes with myofascial pain involvement. So primary myofascial pain is seen in primary care, quadratus lumborum and gluteus medius and trapezius and et cetera. But what about secondary myofascial pain? Are very often seen in tertiary care. In fact, I would say that in the patients who come to the Rambam Pain Clinic, probably 80 to 90% of patients suffer from myofascial pain for whatever reason they have it, together with whatever the primary cause is. Severe osteoarthritis, lumbar radicular pain, TMJ pain, pain from the neck, cervicalgia, and so on. So this is a question, what should we do? So we have patients with migraine and myofascial pain, frozen shoulders, visceral pain, anxiety and myofascial pain, and so on. And the question is, what do we do with these patients? I believe that in these cases, treating only the secondary myofascial pain by itself is self-limited. In other words, you'll treat a patient, do a series of treatments, could be dry needling, could be some manual therapy, and so on. The patient will get better. But we've got a primary cause here, say it's a migraine or the frozen shoulder. If we don't deal with that, then eventually the myofascial pain syndrome is going to come back. So the treatment, in my opinion, in these situations of the myofascial pain as a secondary component should be oriented to giving the patient a window of opportunity so that maybe he can do some extra physical therapy, maybe he can get some other treatment and so on. And the approach should be, yes, you have myofascial pain, it's very unpleasant, we can treat that. We should also treat the primary cause. As an analogy, let's say a patient's got an infection with fever. So the fever is a result of the infection. It's a response to the infection. And it's unpleasant. Having a high fever is unpleasant. So you can treat the fever. You can give paracetamol or whatever and bring the fever down. Patient will feel better. But you also have to treat the primary cause if it's, say, an overwhelming bacterial infection. So you give the patient a window of opportunity to maybe sleep a little bit or whatever. When you bring the fever down, maybe prepare himself a glass of tea or something mild to eat. But obviously, you have to deal with the main cause of that fever. With the pain, treating the myofascial pain syndrome when there is another primary cause will give a window of opportunity, and maybe the patient can use that. Conclusions. Obviously, myofascial pain is very common. We know that in primary care, it's probably 90% of the causes of pain, patients walking into a family doctor. Secondary care down to about 75, 80%, and similar tertiary care. It can be both a primary and secondary phenomena. The diagnosis is independent. Diagnosis of myofascial pain is independent of the primary cause. In other words, a patient can come in with a primary cause, for example, migraine, and you can also diagnose myofascial pain as a secondary, and the diagnosis of that is completely independent. And the treatment, as I mentioned before, depends on the setting and the cause of the pain. So you'd have to decide, do I deal with the primary myofascial pain? That's fine. Do I deal with the secondary myofascial pain? What do I tell the patient? Do I explain to the patient that this is secondary myofascial pain? In other words, it's pain It's caused by myofascial pain syndrome, but because of another, associated with another problem, window of opportunity, we can give a certain amount of treatments, but obviously that in itself possibly won't be enough. So that's it for me. Thank you very much. I hope this has been interesting to you. At the moment, I'm working on writing this up as an article. I've got some help from friends, but I think it's important that we understand that the myofascial pain by itself often is not enough, and you have to look at the patient more deeply to see whether it's a primary or secondary phenomena. Okay, that's it. Nega, back to you.
Simon, thank you very much. It was very interesting. If I ask a question, sure. I work in primary care setup mainly, and I think more primary myofascial pain. I work also in secondary setup where I see more secondary myofascial pain.
Mm-hmm.
The question is, if I see, let's say, a patient with osteoarthritis of the knee who has myofascial pain of the vastus medialis that mimic the pain or come with the pain, treating the myofascial pain of the vastus can have a role in avoiding the osteoarthritic surgery?
Absolutely. Absolutely. Okay, so the primary cause is, let's say, osteoarthritis of the knee, although the osteoarthritis of the knee could have been caused by chronic long-term myofascial pain, causing weakness of the vastus. But let's say the patient has got a chronic osteoarthritis, we know that it exists, and now because of that, weakness of the vastus and so on. And yes, and we do know that treating the vastus will help. Okay, treating that myofascial pain will help. What I will say to the patient in this case is, look, you've got two problems here. You've got the primary problem, which is your knee, secondary problem, which is the muscles that are around, and they are basically feeding one another. Treating your myofascial pain, the vastus and so on, is wonderful. It gives a window of opportunity, and when you have that window of opportunity and you're feeling better, and it's less painful, you have to be active. You have to get on an exercise bicycle and start working that really hard and building up the muscles again. You have to rehabilitate your muscles, and that will help you with the osteoarthritis of the knee. In fact, I'm reminded as we talk of a friend of mine living up here in the area where I live, who came to me with osteoarthritis of the knee and said, listen, I've been offered surgery. And that's exactly what we did. We put him on an exercise program. We treated his myofascial pain, put him on an exercise program, mainly with working with a bicycle, increasing the resistance, and he's fine. He's got crepitations, but he's fine. He's not suffering from pain at all. Age is about 60, 61. So that's my answer to you on this.
Yeah, and it makes a lot of sense because the osteoarthritis, in the sense of the anatomical changes in the joint, is obviously not changing very often. It's getting worse and worse. But the pain go ups and down, and this is the myofascial component that can get better with a physical treatment or to the muscle itself.
Exactly. And of course, if he's suffering from pain, he's going to be limiting himself, he's going to be doing less work, his muscles are going to get weaker, and it's just going to make it worse until eventually he does go for surgery. Interestingly enough, there was a study done, I can't remember exactly where it was published, but I can find it, of patients who underwent knee replacement because of osteoarthritis. And those patients who were needled the night before for myofascial pain of the vastus muscles had a much better recovery afterwards, after the surgery, and shorter stay in hospital and less pain. So it's interesting, the association between a primary cause and a secondary myofascial pain syndrome.
Simon, thank you very much.
You're welcome. Thank you for having me. Great to be here.
Thank you. Zohar, if you can show my screen.
Okay, so I'm going off now, and thank you.
Show my screen, okay. Thank you very much, Simon. אני חוזר לעברית, אני רוצה שוב להזכיר, יש לנו קורס דיקור יבש מתקדם לבוגרי הקורס דיקור יבש הבסיסי, בפלג גוף התחתון במהלך יולי, אפשר להירשם באתר החברה ismm.org.il, ניתן לשאול שאלות או בוואטסאפ שלי או בוואטסאפ של יעל. הקורס מתקיים במכון הכאב בבית החולים בחיפה, רמב"ם בחיפה. יש לנו גם קורסי דיקור יבש בסיסי, הקורס באסף הרופא סגור, הקורס במכון הכאב בבית חולים רמב"ם עדיין יש מספר מקומות, וגם בקורס במרכז הרווחה של מכבי בתל אביב, גם שם עדיין יש מספר מקומות מצומצם, ואנחנו נשמח לתת לכם פרטים. זאת, כאן אנחנו נשמח לראות לכם בוובינר הבא, וובינר מספר 6, שיתקיים לקראת סוף הקיץ, באוגוסט. האורח ככל הנראה יהיה מחול, אני לא רוצה עדיין לחשוף פרטים ולשמור את זה עד שהפרטים יהיו לגמרי סגורים, אבל יהיה מעניין, זה בטוח, נשמח להיות בקשר ולשמוע מכם. תודה רבה.